2 News and the Salt Lake Tribune present Utah's Healthcare Future.
Good evening. This is a town hall meeting, and we're going to be talking about health care in Utah, especially about Obamacare that's coming. We have a story about it before this town meeting. We'll play that now.
So they got it all out.
Emily Young's breast cancer recurred when she was temporarily out of work and had no insurance. She skipped checkups. Cancer spread to her lungs. Doctors said it was fatal. Insurance could have saved her.
I think so too, yeah.
Like Emily Young, 400,000 Utahns have no health insurance. The Affordable Care Act, signed by President Obama, will try to get insurance for almost all of them.
At the Health Insurance Marketplace.
Utahns can sign up now here at healthcare.gov. They'll be able to buy insurance here on the 1st of October, and the federal government will subsidize insurance for those who can't afford it.
My type 1 diabetes goes untreated.
Mike is poor, but now he can't get on Medicaid for poor people. Obamacare would pay almost all the costs if Utah extended Medicaid to Mike and all other poor people without health insurance.
And I pray every night that that will be exactly what happens.
Sometimes we think that the Washington, D.C. is free money. That's probably not accurate.
Governor Gary Herbert and other Utah political leaders are skeptical. They fear Washington won't keep its promises, and they think Utah could do it better.
We want to find a solution that takes care of the long-term health care requirements of our population in the best, most economical way.
4 people we have here who know a lot about this. Next to me, Ms. Judy Hillman, who's with Arches now, a new health insurance company on a new model, but has for years been an activist in this, working mostly for Obamacare. Sitting next to her, Representative Jim Dunnigan, a Republican, I think, from Taylorsville. He's the chair of the Legislative Task Force on Health Care, and he's been the chair of committees. He's an insurance professional. He may know more about this than any other legislator. Sitting next to him, Mr. Nate Checketts, the smartest guy from the administration. Everybody said, said it's your best horse? They said it's Mr. Checketts from the Department of Health. And on the far end, Mr. Jason Stevenson from the Utah Health Policy Project. He works hard. He's going to work hard to try to make this succeed, to try to get it to work. We have Kristen Hodges with us, and she has a question for our panelists. Ms. Hodges.
Thank you. Last year at the end of 2012, my family and I lost our medical benefits. I had to quit my full-time job in order to move to Utah and become a full-time caregiver for my mom. My husband found work, fortunately, but at about 29 hours a week, we don't qualify for benefits through his employer. We have a 9-month-old daughter, and so our primary concern, of course, is for her access to quality health care. I'm wondering, through the Medicaid expansion, I'm wondering what the income limit for a family of 3 would be. I know that right now we're just slightly over that limit, so I wonder if the expansion would help us at all.
Mr. Jason Stevens knows about that. Now, my information is that you make maybe a little under 30,000. I hope that.
Yes.
I hope I'm not divulging anything here I shouldn't.
That's okay.
Is that fair?
Yeah, a couple thousand to do that.
3 people, a little under 30,000. You've got the answer for her.
That would put you at about 145% of the federal poverty level, which actually would put you above the limit for the Medicaid expansion here in Utah, which means that you would qualify for the new insurance marketplaces, which are coming online on January 1st, but you can start signing up on October 1st. And I just crunched a couple numbers before I came here, and you would actually get a tax subsidy that would cover 89% or thereabouts of your health premiums for this new insurance. And it would be good insurance. It would be insurance that would cover care for yourself, your husband, your child, as well as maternity care for if you wanted to expand your family. That's the kind of insurance that's coming with the Affordable Care Act.
And, okay, and that's a done deal. That'll be here.
That'll be here.
Okay. Do you want to talk about that, Ms. Hillman?
Sure. As far as I know, looking at the chart and from what I know of your income, you would be paying out of pocket about $103.
$104.
$104.
I have the chart here. Looks like you're paying taxes, but actually, this chart says $30,000, 3 people, $104 a month. I take it.
Right. So come October 1st, you'll be able to choose from a broad range. We think a broad range of plans, and I will say, from Arch's perspective, we know there are going to be some affordable, high-quality plans to choose from. I can also say, yeah.
Are you going to bid? Are you going to be on the market? Is Arches something she can choose if she wants?
Arches is a very unique product that's going to be out on the exchange. It's going on this co-op model. It was actually established through loans from the Affordable Care Act. The idea was to put plans out on the marketplace that could model exactly the kind of behavior we want to see in that marketplace. So Arch's plans are built around patient-centered medical homes. The idea is that your family's going to have the right incentives, and your doctor's going to have the right incentives to give you the care you need and to keep you in the right setting and keep you on the path to health.
Representative Jim Dunnigan, you're an insurance professional. You've done this for, I don't know, decades. Is this going to work? Is it going to be as good as smooth and as good as people say?
No. The introduction is very likely to be rough, and there's going to be a lot of bugs that will need to be moved out. For the income that she stated, there will be some very nice subsidies, and she'll probably be able to get some very good quality coverage at an affordable rate. So, it'll certainly work for her, but there's going to be some rough edges around it.
This exchange is being run by the federal government in Utah. They're not by the state. Do you know what? We could have run it. Normally we say, we'll take it on. We like to, as much control as we can get right here in Utah. Do you know why we decided to let the feds run this thing?
Well, Representative Dunnigan will be able to comment on part of that. Let me give my part, but I think he was a key part of that decision too. The state was already running its own small business exchange and was already doing that before the Affordable Care Act passed. And there are pieces of that we thought were valuable as a state and wanted to keep. And there were things that were required under the Affordable Care Act for the individual exchange that I think the state was not comfortable with. And so that was the reason to sort of divide those and let the state run one piece and let the federal government run another piece. I don't know if you have.
He refers to you, and my recollection is it was legislators who said we don't want to get mixed up with those guys.
Well, we love the federal government.
Yes, okay.
But we will actually have 2 exchanges in Utah, one for small businesses that, as Nate said, the state will run, Avenue H. There will be another exchange for individuals who do not have employer-based coverage, and that will be run by the federal government. One of the reasons that we did not want to run that exchange is when people drop coverage, we need to notify the federal government. We don't want to rat out fellow Utahns to the federal government when people drop coverage.
We have a question here from Ms. Dobner, Jennifer Dobner of the Salt Lake Tribune, who is a reporter who covers this stuff.
Yes, I do. You guys have been talking about the exchanges. I want to know, how will somebody like Kristen Hodges be able to access the exchange? Who's going to help her figure out what's best for her family? What kind of information she needs to bring with her when she goes to fill out an application? Who's going to help the public figure this out?
You want to talk about that?
Well, yeah, I can, or Jason.
Go ahead.
But really quickly, there are going to be these navigators designated for Utah, and we won't know, unfortunately, till August 15th, who are the official navigators of Utah. But I think it's going to be a good crew, and they're going to be well networked together. Aside from that, every community health center in the state is going to have enrollment assisters there. So in almost every community, you'll be able to find help. People do need in-person help, we realize. For now, people can get ready right now by going to healthcare.gov. You can put in your information there and get absolutely ready for the big decisions October 1st.
Are you going to be a navigator? Do you want to be a navigator?
We'll have people on our staff who are going to be navigators, and we hope to actually be one of those grant recipients at UHPP. The one thing I wanted to add, though, was that there's also, right now, people can, as Judy mentioned, go to healthcare.gov. The website has a pre-enrollment checklist that you can look at. You can get information about what you'll need when you start signing up for coverage on October 1st. There's also a toll-free number you can call. Let's say you don't have the internet at home. You can go to 1-800 1-800-318-2596.
Say it again.
1-800-318-2596. That toll-free number is operational right now. I called it just before this meeting, and a very nice person answered the phone.
You actually got a person.
Well, it might have been a robot. Sometimes you can't tell these days.
Okay, you might have got
But they did ask me what state
a
I
very
lived in.
nice robot. Who picks the navigators? Or will the administration pick the navigators?
The federal government does.
The federal government
that's a
chooses
federal
that.
grant.
You guys don't have anything to say about it.
No, we don't.
Okay. Okay. We have Mr. Royce Van Tassel. He's from the Utah Taxpayers Association. The reason I asked him to come is because he wrote a piece in the newspaper which introduced me to a study that seems to me germane. Would you ask a question, please, Mr. Van Tassel?
Appreciate the opportunity. As many of you know, Oregon sort of had something of a natural experiment to evaluate the impact of participating in Medicaid, and the results of that just came out the second year a few months ago that showed it was indistinguishable, statistically speaking, who had participated in the Medicaid program versus those who were also eligible but weren't able. It's rather curious that, when you're talking hypertension, diabetes, other very treatable programs, participating in Medicaid didn't seem to have any impact. So given that the cost will be significant, and given that you can't seem to tell, at least based on this one natural experiment, the participants from the non-participants, why should Utah expand?
You're nodding your head as if you're getting ready to fight there.
Well, my wife is a family doctor who works here in Salt Lake County, and if she could turn around hypertension and high blood pressure in 1 to 2 years, which was the span of that study in Oregon, she'd be a wizard. She wouldn't be a doctor. These medical problems take time. And the one thing about that Oregon study, what it did show, was that it prevented financial bankruptcy, catastrophic financial bankruptcy for those families that were on Medicaid, which, after all, is one of the reasons people have insurance.
Did you want to comment on that?
Yes, one of the things that we hope if we expand access to health care is that costs decrease, people have better, healthier outcomes, and better financial stability. That study showed that when they expanded Medicaid, there was better financial stability, health outcomes did not decrease, and costs did not decrease. What we want to do, ideally, is get people so they have insurance through Medicaid or private commercial insurance, and see the utilization of emergency rooms decrease because they can go to a doctor. That did not happen. The ER usage stayed about the same.
And it's important to measure quality in Medicaid. That's something that we want to focus on right now. The state just started accountable care organizations where we're contracting with health plans to provide these types of services, and we're developing with them about 20 measures that look at hypertension, cesarean rates, low birth rates, to see how we're doing in those areas.
If I were to say what's the chief decision that we have to make at a state, it's whether to expand Medicaid is what I'd pick. And I guess you're involved in that. Could you explain it to people a little bit?
Sure. The governor set up a process. This, as you said, this is a big decision.
What's the decision?
Decision to expand Medicaid?
Yeah, can you explain a little to people what that means?
Sure. So Medicaid right now is a categorical program where you have to fit in a certain group. You need to be a child or a pregnant woman or a parent of a young child in order to qualify. What the expansion would do is it would allow most adults to qualify even if they don't meet these special categories.
Provided they're poor.
Provided that their income's below certain levels, yes. And for a family of 4, it's about $31,000 or so.
And the governor will have the first whack. The legislature's going to get in on this, but the governor's going to make the decision first, right?
The official way the state will notify CMS, the federal government, that it's doing that is that we will actually submit a state plan to them about how we will do that. And there was a bill passed in the last session that said if the governor's going to do that, he needs to complete a study with a consultant to see what the cost and benefit is. That's been done. There needs to be a charity care group that will look and see what charity care might look like if we decided to do that instead of an expansion. And that needs to report to the Health Systems Reform Task Force. And then the governor has to make 2 reports to the legislature on that.
In the House, last session, it's true that in the end you voted this law that he said, but in the beginning you said we don't want any part of it. The House passed a bill, got beaten the Senate, said we won't go forward. Are your colleagues of the opinion that we should not go forward still? Can they be talked around?
When we voted on that bill in the House, we didn't know what a Medicaid expansion would cost. We have a better idea now of what it will cost, so we have some better information. If I were to guess right now, I think it's going to full expansion is going to be a tough go in the House. But we have, as Nate said, we've got several working groups evaluating this, and we have a full range of options from charity care, partial expansion, full expansion to no expansion.
Your colleagues are going to want to know what you think. Tell us what you think.
I'm not done with my studying yet, but thank you for asking.
Okay, so you're keeping your powder dry.
I am. I'm participating in some of these work groups, and I want to see what the results are.
Okay, now, the federal government will pay almost all the costs of this, or at least they say they will. In fact, the governor said to me he thinks the state budget might make a little money on this thing if we go with it. 4,000 new jobs. Is there a good reason to go with it? Is there a good reason not to go with expanding Medicaid?
Well, Arches believes that we've got to cover all of the uninsured, and I think there's plenty of evidence to show that for that population, Medicaid is the only game in town. So it's a no-brainer.
If Utah doesn't expand, 120,000 about people won't get covered. They won't be able to go to the exchange, or not all of them will, or do you know?
They won't actually be able to get the tax subsidies on the exchange. They would qualify for some catastrophic care under a hardship exemption, but that wouldn't be the same as having full health coverage.
Okay, if you want to talk.
Well, it's estimated that about 120,000 people under full expansion of Medicaid would have newly available Medicaid services to them. If we don't expand, about half of those people will still have subsidized coverage available through the exchange, just like the lady that we first talked. So half of those will be taken care of with the exchange.
What's the chief reason not to do it? There's some reasons to do it. What's the biggest reason not to?
One of the biggest ones is cost. Although the state saves money in the first 3 years when the federal government pays 100%, after that their share decreases, and it's going to cost us maybe $50, $60, $70 million per year to do that by the time that we have to take the full freight of it.
Okay, so
new money, ongoing money.
Okay, it'll go up in about 10 years, I
Well,
think.
it goes up starting in the fourth year.
Yes.
It's kind of a loss leader for the federal government.
Yeah.
They pay 100% for 3 years, and then it starts to taper down.
The study I saw was over 10 years, $2.9 billion federal money, $260 million, I believe, state money. Is that the chief thing that's keeping causes the governor to say he may not expand?
So cost is a big issue. The governor's concerned federal dollars are still tax dollars, and what's the appropriate way to spend tax dollars. And he's also very concerned about coming up with the state share. Those resources battle against education and other roads and other things that we need in the state, and those are tough decisions for legislators and the governor to make when they're faced with those.
Jennifer Dobner, Salt Lake Tribune.
So you've been talking a little bit about Medicaid expansion, and the state is exploring various options. What might be alternatives to full expansion? Is there a partial expansion? Is there charity care? Are there segments of the community that we could cover, like people with behavioral health problems? How much flexibility do you think you might get from the federal government? And number two, am I correct in my understanding that we don't have to make a decision this year? We could opt out for 2014, make a decision later, but what do we lose if we do? I know that's three questions.
So you are correct that there's no deadline for the state to opt in. We can do it at any point in time. It's not a use it or lose it. We do lose some federal funding, and that the 3 years of 100% federal funding starts in 2014. And then so, after that 3 years, it starts tapering down. So there's some financial loss, but there's certainly no deadline.
If we're going to do it, if 'twere done, then maybe 'twere best that we're done quickly. I mean, if we're going to do it, we might as well get all the money, right?
Well, there's another major concern, and that is, do we believe that the federal government will follow through on their end to pay 90%? And we have a good example with the federal high-risk pool. They said they were going to fund it until the first of this coming year. End of March, they notified us and said, we have no more money. We can't, stop taking insured. So we don't know that they'll be able to fund it.
Afraid they'll get us in, then leave us in the lurch.
That's right.
Although they've never done that before with Medicaid. They've always kept the match rate since the beginning of the program, and the match rate is actually quite advantageous for Utah under the expansion. It goes from the federal government paying 70% to the federal government paying 90% ongoing. And I think that actually brings up this economic development argument that this is a big investment that Utah can make in our healthcare infrastructure. If we're really focusing on STEM education in our high schools and elementary schools, those jobs are going to be here in Utah in our medical field.
Jennifer Dobner.
So I do want to know what kind of flexibility you think you might get, because Arkansas, for example, got some flexibility to use premium subsidies for people who would qualify for Medicaid and put them in the private market. Are we looking at those kinds of things in Utah? Do you think you're going to get that kind of leeway like you got with the bifurcated exchange system?
Go ahead, Nate.
It's definitely what we're looking at. I mean, this is part of the reason why we're having these work groups, is to go out and explore what the other states are doing, go sometimes beyond what we're hearing in the news and finding out if we can talk to their Medicaid director and talk to the federal government and find out what exactly is being approved in those states and see if that might fit here. There's a lot of strings attached when they make these approvals, and are we okay with some of the things? Line those out for the governor and for the legislature so they know if they say, we like paying people subsidy, we pay a subsidy so that they can participate in the private exchange. What are the strings with that? How might that work for us?
Can you give us a peek as to the things the concessions you want? For example, on the exchange, Utah keeps its own business exchange. Can you tell us what the governor's saying to the Secretary of Health and Human Services? We need this if we're going to do it.
We haven't got to those bottom line issues yet, but we are talking about in the work groups issues similar to what we've been talking about here. Can Medicaid pay a subsidy to put someone in the exchange? Can we provide things through managed care? Can we require people to participate in the exchange? Those are the types of decisions we're looking at in these work groups.
We have a question here from that's on Twitter. It was tweeted in by Adrian Jenkins, and we'll put that up now. What can we as consumers do to reduce health care costs? You have an idea?
Yeah, well, we think we have some good ideas, and that's the beauty of this co-op model, is that we can really build from what we know works in our healthcare system. And one of the things that works is to really have patients working directly with their providers in sort of a teamwork approach. It's called patient-centered medical homes. But the idea being that patients need to have their care well coordinated. They need to know what their health issues might be as they go in, a kind of a health assessment. They need to work with their doctor on their health care goals and really be able to take charge.
And that'll hold down costs?
Insurance should be a tool for doing those things that we should have been doing all along between patients and doctors. That's Arch's premise.
Do you know anything that would hold down costs that either people could do or somebody could do? So far, nobody in the world, or at least nobody in America, has succeeded in holding down costs.
One of the latest projects we're working on is looking at value-based payments, trying to make payments first to health plans based on a risk-based organization where we pay them a certain amount of money to provide all the care for an individual, and then pushing that further down, them working with doctors and hospitals to try to make similar payments that encourage people to make effective use of their care, not necessarily pay them for each time they go to receive a patient.
Okay, the Center for Disease Control that says well over 50% of our healthcare costs are determined by our behavioral choices. So if we are willing to get a little more exercise, coordinate with our doctors, eat healthier, there's plenty of money that could be saved, but we've got to get involved to do it.
And the Affordable Care Act actually puts a lot of money into wellness plans that do that.
Question here from the audience.
So this question's in regards to the mandate that requires businesses with 50 or more employees to provide health care. Will that extend to the nonprofit sector as well?
Do you know? Does that?
I believe it does.
Mm-hmm.
Yes,
Okay.
it does.
Okay.
You've got some nonprofits that are, reducing the hours of part-time workers to be able to avoid that penalty. We've seen that.
Could one of you explain what we're talking about here?
Sure. Under the Affordable Care Act, businesses with more than 50 employees are asked to provide, quality health insurance for their employees. And most already do, about 95% do. Those that don't would have started to face a penalty in 2014, but that was recently delayed until 2015 to give them more time to work that out. The one issue with that is that the employees have to work more than 30 hours. And so some employers are actually cutting their employees down to 29 hours. But the more you read about that, you realize that as an employer, that's a risky proposition, because you need to hire more people, which means more training, more uniforms. And it might not be the best investment to make.
Sir, you had a follow-up.
So will there be any federal assistance to help pay for those costs? Like, for example, with schools. I know I work with a school in a very low-income area, and we tailor our school to a very low-income population. So we may not necessarily be able to pay for that.
Okay, let me see if I understand. You have a school, you've got people who work there, and you don't insure all of them. You're afraid, or maybe not any of them, and if the mandate hits you, it's going to hurt your school.
So I'm curious if there's going to be any sort of federal assistance to help with that.
One suggestion would be for any large employers that are listening, or folks that maybe could influence large employers, is if you are going down that road where you're reducing the hours and therefore reducing the income of part-time workers, we would ask you to please help those workers find their way into the individual marketplace. That's one thing Arches is doing, is trying to reach out to those employers and say, well, at the very least, let's help them get affordable coverage.
Okay, why shouldn't every employer simply say, I'm not going to give health insurance, I'm going to, you guys go to the exchange, and there you'll get a very good deal, and you may get some subsidy too.
That's where we're headed.
Is there any reason that won't happen?
Well, sure. The same reason that employers offer health insurance today, and that's to provide a benefit to attract and retain employees. So much of that will continue on.
Mm-hmm. We have a question here from the audience.
Yes, my name is Bryce Christensen. I'm the chairman of the College Republicans here at the U. I know a lot of people that are really concerned that the Affordable Care Act is going to cause for the America's Best and Brightest to shy away from the healthcare industry. Is this a real concern, and why?
Let's start with you, Mr. Stevenson.
Well, in Utah, we actually just increased the number of slots in our medical school by 20 this year, thanks to a bill that passed the legislature. And I know there's always been more and more people trying to go to medical school, and we have a great PA school here that's always oversubscribed, so I don't see that happening specifically in Utah. And I think there's always going to be a need for healthcare, especially as our population gets a little bit older. There's going to be need, and that's where the jobs are going to be.
Mr. Dunnigan, can you explain why it would?
Well, demand is going to increase. To the extent that more people get health insurance, they will access more health care, and we will need more health care providers. One of the challenges of the Federal Health Reform Act is that we may not have enough providers to handle this onslaught of people that have new insurance.
We have a question here from Monica McDonald, who tweeted, how high does the autism rate need to be before we make insurance cover effective therapy for these children? Right now in Utah, most autism parents can't get their insurance companies to pay. Is Obamacare going to fix that?
Well, I have one idea of the co-op model, and I'll just put this out there. I'll stop with my marketing in just a minute. But one idea was that if we can be effective in reining in costs and delivering good care for our members, the money we save, the co-op members get to decide where we spend it.
Okay, but to start with, you're not going to cover autism.
I don't know. That's not my decision yet. I'm new.
Does anyone know?
There's 3 pilots that are going on in the state right now to look at autism coverage and how that might benefit families, what the cost of those might be. There's one that's being run by Medicaid, there's one that's going on with state employees, and then there's a third pool that's also being run by the state. They're all looking at what those costs are and what the benefits might be.
October, you start signing up in the exchange. Will you get autism coverage? Will it be offered in the exchange? Will it be subsidized? You've got a very short time to answer.
That depends on what the insurance companies are going to offer to our citizens. I think it would behoove them to do that, given the rates we have here.
The answer is we don't know exactly, but maybe it'll help a little. We're out of time. Thank you very much to the audience. Thank you very much to the panel. Big decisions coming up, important time in health care. Good evening. Thanks a lot.